So, Lecture 5 in this respiratory package is about ventilation monitoring and entitled CO2 monitoring. And this lecture is delivered by Jonathan Downham. Jonathan is an advanced critical care practitioner at Warwick NHS Foundation Trust. So you're very welcome, Jonathan, and thank you for coming along to do this lecture for us.
That's my pleasure. Okay, so I've been asked to cover ventilation monitoring and entitled carbon dioxide. So it's important to be aware that when you're looking after a ventilated patient in the intensive care unit, there are a number of routines that you will be doing throughout your shift. These are going to be done with all of the ventilated patients, and they become something that we do very regularly, 24 hours a day. So one of the first things you're going to be doing when you have the patient handed over to you is that you need to make sure that the area is safe. So that's about completing bedside checks. So you want to make sure that your suction equipment is working. So that involves actually turning it on, make sure it goes to the appropriate pressures, making sure all the connections are connected well. You need to check your bag valve mask and your artificial airways if there are any present. Make sure the bag valve mask inflates appropriately when you turn the oxygen on and there's no leaks, and obviously that they're by the bedside. You're also going to be checking the ventilator settings. Now, commonly in the UK, what we do is that we will discuss those ventilator settings with the person handing over to us, what they were, and then you will just ensure that they remain the same as what was handed over to you. Those ventilator settings might change during the day, depending on what the medical team want to do with the patient or how the patient is responding to treatment. So you need to be sure that the ventilator settings are as they should be. You're also going to make sure that the patient is being monitored appropriately. So look at the screen behind them. Does everything seem to be working okay? Has the pressures changed, for example? Has the blood pressure changed significantly since they were last monitored? Has the heart rate increased? And check your alarm settings as well. So make sure that you're happy that the alarms are set within the boundaries that you are going to accept as being okay for your patient. The second thing you need to be aware of when you're caring for the ventilated patients is that you need to ensure that the patient maintains a patent airway. And obviously for a ventilated patient, that's going to be an endotracheal tube. So an endotracheal tube obviously sits below the vocal cords. And one of the things that ensures that the air goes into the patient and not just out from the atmosphere is that there's a balloon at the end of that tube. Now, that balloon is there to ensure that the air goes in, not to hold the tube in. And one of the things that we need to check is that that balloon is adequately inflated. And we'll often use a pressure manometer to make sure that the pressures in that balloon aren't too high. If it's not adequately inflated, then you can usually hear the patient making a gurgling noise, and the ventilator volumes will go down. So that's something else that you need to be aware of during the day and something that you will check very regularly. You need to be sure that the endotracheal tube hasn't moved. And when an endotracheal tube is put in, there are centimetre markings on the tube, and it will be noted where the patient's tube is at their lips and where it's tied at. You need to know that that hasn't changed. So has the tube moved in or has the tube moved out? So you need to be aware of those markings, and that's often written on the chart, or if it's electronic, it will be noted on the computer. And also confirm that it's secure. As I said, it's not the balloon at the end of the tube that's keeping it in. It's the actual tapes going around the patient's face. And there's various different devices these days for securing the tube, and you'll just need to get used to the one that your hospital uses. Making sure it's secure. You should be able to, if it's just tapes, be able to get a couple of fingers under, but no more. If it's any tighter than that, you can be risking pressure area problems. If it's any looser than that, then the tube can move in and out. You need to also then be monitoring pressure areas around the lips and tongue. The tube obviously sits on the tongue and can sit on the lips as well. And you'll be monitoring those very regularly to be making sure that pressure areas aren't forming in those areas. And often what you'll do is that the tube will be moved from side to side, and you'll be regularly checking in the patient's mouth for any evidence of any pressure sores or any oral thrush, which can often occur. And again, like I say, under the ET securing device. So have a look under there. If it's wet, if it's blood stained, if it's got secretions on it, then that's something that you need to change as well. You need to assess regularly the oxygen saturations. So that could be a probe on the finger or a probe on the ear. You need to be aware of the saturations that the medical team are happy with. It can vary from patient to patient. Some patients we aim lower, some patients we aim higher. But you just need to be aware of that. We'll also be assessing for bilateral breath sounds. So that involves listening to the patient's chest and just making sure that we can hear air going into both lungs. Sometimes what can happen as the tube moves in, that it will go down the right main bronchus, and therefore you're only ventilating one side of the chest. You also need to assess the patient's respiratory rate. Now, depending on the ventilation setting that they're on, they can either be breathing for themselves or it's the machine doing the ventilating completely. But you need to be aware of that one way or another. What's the patient's ventilation or respiratory rate? Checking the vital signs is something that we do as a standard on an hourly basis in the intensive care unit. It could be that we might do it more frequently than that if the patient is particularly unstable. It may be that if the patient is perhaps not ventilated and is perhaps become a high dependency patient, that we'll do it less frequently. But just be aware of how often we're doing it. And one of the things to note is the blood pressure. Often after the ventilation settings is changed, sometimes the blood pressure can be affected. Mechanical ventilation obviously causes positive pressure in the patient's lungs, and that can sometimes put pressure on the patient's heart, which can cause an issue with their blood pressure. The other thing that we need to check regularly is assessing the patient's pain, anxiety, and sedation score. And there's various tools to do this. Now, obviously, you might ask, if the patient is sedated and asleep, how am I going to assess their pain? There are visual scales which can be found on the internet, which can give you some clues as to whether the patient might be in pain or not. Many intensive care patients will be having, as well as the sedation, they're going to be having a strong analgesic as well. So it may be that if the patient appears in pain, that maybe the analgesic can be increased. If the patient is able to respond to you, and many of our intubated patients will be, certainly as they start to wake up and we start to wean them from the ventilator, it could be that you can assess the patient using the 1 to 10 pain scale, where 1 is little or no pain, 10 is the worst imaginable. They may be able to understand and communicate that to you. Sedation is obviously something we're going to use with a lot of our patients. And one of the key things that we are aware of is that if our patients are too heavily sedated for too long a period of time, this can impact on their recovery time post-intensive care. So understanding the sedation scales is very important, and we use something called the RASS score, and that's something that if you're not used to intensive care, one of the ITU practitioners can explain to you. But basically it's a score that tells us whether the patient's too heavily sedated or whether potentially they need a little bit more sedation. There's a sweet spot that we like to hit for that. Suctioning the patient is something that we will do very frequently for our patients. Obviously, they can't clear their own secretions because they've got a tube bypassing their vocal cords. They can't get the positive pressure to cough up their secretions. So we do need to suction them. These days, we tend to use what we call inline suction. So you don't have to actually break the suction, the ventilator circuit at all in order to suction them, which is important for things like infection control. And you'll be shown how to use those if you're not familiar with them. But some of the important points is that it's sensible to hyperoxygenate the patient before and after suctioning. And most ventilators these days have a little button you can press which will give them 100% for a couple of minutes. So if you do that before, then hopefully they're not going to desaturate and become hypoxic for any period of time. Try and suction for the shortest time possible. Obviously, you want to get down into the lungs and clear those secretions, but once you feel that you're far enough in, then pull that suction tube out, especially as the patient starts to wake up. If you hit the carina, the division between the right and left main bronchus, that will make the patient cough very hard, and it's very uncomfortable for them. So do it for the shortest period of time possible. Use the lowest pressure you can. So your suction machines will have a dial on them where you can set the pressures, and the hospital you work at will probably have policies for that as well. And once you've suctioned them, you need to be aware of the secretions that you're bringing up. So you might be asked, are they yellow? Are they green? Have they changed? Are they frothy? And perhaps one of the more important things is that if you have caused a little bit of trauma, there may be some blood in the secretions. This is quite common. As long as it's not too much, then we can probably tolerate that. But you need to be aware of it. And if it changes dramatically, then somebody needs to be aware. Blood gases is something that we do very, very frequently for our patients. We try to do them as infrequently as we can, but if the patient's particularly sick, for example, blood gases or acid-base balance is something that's going to tell us what we need to do for that patient. We perhaps need to help with their ventilation. We perhaps need to be more concerned about their level of sepsis. We perhaps need to worry about their kidney function, for example. So acid-base balance, something reflected in an arterial blood gas, is very important and something that we will do very regularly for our patients. It helps us wean the patient from the ventilator. Potentially it helps us decide whether they might need dialysis to support their kidneys or more intravenous fluids. Lots of different information from an arterial blood gas, and that's something that is done very, very frequently. They'll have a radial line into their artery, possibly. It could be in another place, but commonly the radial artery in the wrist is the one that we use, so we can take the blood without causing them any more discomfort or distress, hopefully. As I said, ensuring the patient's level of sedation is assessed regularly using the RASS score, the Richmond Agitation and Sedation Score. That can make a big difference to the patients. So that's some of the things that we're going to be doing. We're obviously going to be giving them their drugs as well. We're going to be giving them intravenous fluids. We're possibly beginning with them nasogastric feeding, so observation of those, and the input and output is very important as well, monitoring that to make sure that they don't become dehydrated or fluid overloaded. So care of the catheter is also important. So how are we going to recognise the principal signs of ventilation success or failure? This is a question that I was asked to cover. I think probably the important thing is that we need to understand what we mean by success or failure. So ventilation success is probably the final point of ventilation success, is that you're going to wean them from invasive ventilation, that they're going to be ventilated for whatever cause, and then gradually as they become better, they're going to start breathing for themselves, and the ultimate aim is that we're going to be able to take that endotracheal tube out and the patient is going to be able to breathe for themselves. That's the ultimate success. However, many of our patients, once they are weaned from a ventilator, will often be weaned onto another kind of non-invasive ventilation. That's becoming more common now. High-flow nasal oxygen is something that we'll often wean our patients to, or a non-invasive ventilation, so the tight-fitting face mask or nasal mask is something that we'll wean them to, often if we think that they might struggle post-extubation. So that is a measure of success. How are we going to know that we are working towards success? So we look at several factors really when we're going through the weaning process with ventilation. So first of all, are their oxygen levels improving? So that's their saturations and their oxygen levels on their arterial blood gas. Now, obviously, if these improve, but we're continuing to have to increase the support, then that's not the same as if these continuing to improve, but we're giving them less oxygen. So we want to see those improve whilst we're giving them less oxygen as well. We can obviously give them up to 100%, but ideally we'd like them to be down as a minimum, really something like 30 to 40% before we start thinking about taking them off the ventilator or starting the weaning process. Airway pressures are very important. Our ventilators push air in. You and I suck air in, the ventilator pushes air in. So that's positive pressure ventilation. So sometimes the airway pressures can become quite high, especially with the sick lung. Typical COVID patient commonly had very stiff lungs, so the airway pressures required to get them in were quite high. If we can get those airway pressures to come down, and the patient continues to ventilate well, then that's also very important and is a sign that the patient's ventilation is improving. Secretions, if the patient had a lot of secretions or a lot of thick green, yellow, frothy secretions, for example, we'd like to see them reduce as well. It's difficult to extubate a patient who's still bringing up a lot of secretions. Post-ventilation, certainly if they've been ventilated for some time, one of the problems they're going to have is they're going to have a very weak cough. So we need to be sure that if they need to cough, they can bring up their secretions, and we don't want lots of secretions for them to have to do so because they're going to be too weak to do so. Is the patient able to tolerate the weaning process? Many patients, when you turn their sedation off, don't cope well with the ET tube initially. Sometimes it makes them cough a lot. Sometimes they'll be fighting it. They'll be trying to pull it out themselves when we're not ready for them to do so. They won't be following commands, which is very important once they're extubated, that they can follow commands as well. So we need to be sure that the patient is able to tolerate the weaning process. If, for example, we wake them up and they become delirious, which is a very common problem with the intensive care patient, then that wouldn't be the optimum time to extubate them because they won't cooperate with us, and potentially that could lead to further problems. So we need to be sure that they understand what we're saying to them, and that they can follow commands, and that they have a reasonable chance of coughing anything up should they need to do so as well. The final thing is that we need to be assured that the patient can maintain their own ventilation without the ventilator. They may need some other support initially, like we say, but we do need to be sure that once that tube comes out, that the patient is going to be able to breathe for themselves. So hopefully they're not breathing too quickly. They can talk, they can communicate with us, they understand what we're saying, they can obey commands, and they've got a good cough. Then that's probably the time, if the oxygen levels are low enough, that we can think about extubating them and moving them on a step. So failure, what is failure? Well, failure really is about, for example, and I'll go to the bottom of this slide first, for example, increasing hypoxia, hypercapnia, or acidosis. So do their oxygen levels continue to be high? Despite the amount of, do the oxygen we give them continue to be high, and their oxygen levels themselves, their saturations and the blood gas oxygen levels are low? Or is it a carbon dioxide issue? Is their carbon dioxide levels remaining high? And if you have a patient with very high carbon dioxide levels, they're not going to breathe effectively if you were to extubate them, and the problem will just get worse. Or is the acid-base balance still very deranged? Do they still have an acidemia? If that's reasonably severe, then waking them up and trying to extubate them is also not a sensible thing to do. Another definition of failure would be that we continue attempts to wean without success. So we do have patients that we will think, okay, they're ready to be extubated. We extubate them, and unfortunately, we then have to re-intubate them because it hasn't worked. Sometimes this cycle can happen 2 or 3 times, and sometimes if the patient is with us for long enough, then commonly what we'll do is we'll decide to go down the route of the tracheostomy for lots of different reasons. Patient comfort is the main thing, but the other main reason is that if you decide to take them off the ventilator, putting them back on the ventilator is simple as just reconnecting the trachea rather than having to re-intubate them. So if the patient doesn't breathe well without support, so if they don't sync well with the ventilator, if the respiratory rate increases, that's a sign of failure as well. So that's the 2 sides of success and failure, and recognizing that is important to decide whether you're going to move forward or increase the amount of support that they're needing. The next part that many people don't encounter very often, other than in intensive care, perhaps in the emergency department and probably in the operating theatres, is the end-tidal carbon dioxide monitoring that we use. The important thing to understand with carbon dioxide monitoring is that as the patient breathes out via the ventilator, via that tubing, the carbon dioxide is breathed out. And you can see from the curve on the right of this screen, you can imagine that the top of the curve is as the patient is maximally breathing out, and the bottom of the curve is as the patient's breathing in. So carbon dioxide is being shifted out as they breathe out, and then it's just oxygen coming out as they breathe in. There's two important roles that carbon dioxide monitoring play for us. When we intubate the patient, so when we decide to put a tube down, the crucial sign as to whether we've been successful and we're in the lungs and not in the stomach is the end-tidal carbon dioxide monitoring. So what you'll often see the team doing once the tube is in is turning and looking at the monitor and seeing when the end-tidal carbon dioxide is being produced. If it is, you're sure you're in the lungs. If it isn't, there's every chance that you're in the stomach, because the stomach doesn't produce carbon dioxide, the lungs do. So there's your waveform. Once the patient's intubated, that waveform will be up on the screen. How does that help us once the patient's intubated? What's important to understand here is that breathing is a two-part process. So you've got oxygenation, the amount of oxygen we supply, and then you've got ventilation. And don't get this confused with the ventilator. Ventilation just means how well expanded the patient's lungs are. Your COPD patient, your bronchospasm patient, your ARDS patient, so acute respiratory distress syndrome, which is what a lot of the COVID patients struggle with. They struggle to get the gases out of their chest as well as getting the gases in. And if you can't get gases out of your chest, then one of the gases that will build up is carbon dioxide. So in other words, if you're not ventilating effectively, then the carbon dioxide levels will build. And this is commonly the patients who have the COPD with the type 2 respiratory failure will have high levels of carbon dioxide because they're not able to breathe it out because of either obstruction or increased resistance or poor compliance of those lungs. And we need to keep the carbon dioxide within certain ranges. And we got the same thing with the end-tidal CO2. We try and keep that within certain ranges as well. If it starts to rise or it starts to fall, then it can indicate a problem with either the patient or the ventilator. So if it's rising, for example, the patient might need to take bigger breaths. You might need to give them bigger tidal volumes. In other words, each breath we might need to make slightly bigger. Or it could be that there's an obstruction. Now, that could be an obstruction with the machinery. So the tubing's kinked, for example. You've got water in the tubing. You've got water in the filter. Or it could be that there's an obstruction in the patient's suddenly having a severe bronchospasm. And therefore, their end tidal will actually reflect that. If it's falling, it could be that we're over-ventilating the patient. So we're giving too many breaths, their end tidal will start to fall gradually because each breath will emit less carbon dioxide because we're doing it more frequently. So your end tidal is quite important, and it's something that we use to help us reflect in the patient's condition. And one of the key things with the falling end tidal as well is it could indeed be a problem with the patient's circulation. If the patient's cardiac output, i.e. the amount of blood that they're putting out from their heart, starts to fall dramatically, then you're not getting so much carbon dioxide delivered to the lungs because it's the heart that's carrying the blood around, so their CO2 could start to fall as well. So you need to be aware of rising and falling end-tidal carbon dioxide levels. Recognizing ventilator-associated complications is quite important as well. Putting somebody on a ventilator can cause sometimes a lot of problems. We don't want them ventilated for very long because of the problems that it can cause. So this is why we're keen to get our patients extubated as quickly as is safe to do so. And going back to some of the signs and symptoms that we look for, you will understand hopefully, when we should be doing that. So some of the problems, so there can be cardiovascular problems. So like I said, ventilation is a positive pressure issue. So you're increasing the pressure in the thoracic cavity, which can also increase the pressure on the heart. So one of the terms you'll hear is positive end expiratory pressure, or PEEP. Now, if you increase the amount of PEEP you give to a patient to improve their oxygenation, you can squeeze the circulation a little bit and you can cause them blood pressure problems as well. So consequently, you require close monitoring of their heart rate and their blood pressure. You can cause something called barotrauma or a pneumothorax. So barotrauma is really where you've just got such high pressures in the chest that alveoli will start to pop, and you can start to cause problems that way, causes damage to the alveoli and to the overall integrity of the lungs. So one of the things that we measure on the ventilator is something called peak and plateau pressures. I won't go into the numbers now, but basically that's why we monitor them, because we don't want those pressures to get too high because you're causing more harm than good as a consequence of doing so. And often that's a problem with our patients with the very stiff lungs, the patients with the COVID lungs, for example. Ventilating them becomes problematic because the pressures you're ventilating them at to get them to oxygenate, to get them to clear their carbon dioxide, become too high, and it can potentially cause damage to those lungs as well. We also need to report if there's a sudden drop in saturations, climb in airway pressures, or a drop in blood pressure, which is a reflection of those problems, that it could be a barotrauma or a pneumothorax. If the pressures are so high, then you can actually need to insert things like chest drains because of a pneumothorax. Not that common, but something you need to be aware of. Infection is one of the biggest problems with ventilating somebody. If you can imagine, you've put a big tube down straight into their airway. You've bypassed all those lovely cilia that knock everything up and we cough out. You've bypassed a lot of their protective mechanisms. And despite our best efforts, some of these patients, unfortunately, will develop a ventilated-associated pneumonia as a consequence. But we try and reduce the possibilities of that happening. And again, if we go to the bottom of this screen, to minimize the risk, we try and implement best practices, so strict hand washing, aseptic technique with suctioning. And like I say, with the inline suctioning where the circuit isn't broken, that's helped improve that as well. We elevate the head of the bed to 30 to 45 degrees unless that's contraindicated. So somebody who's perhaps got a spinal problem where you can't do that. But we elevate the head of the bed. And this is really to try and reduce the risk of any aspiration from gastric contents. Sometimes there can be some gastric reflux because the patient's very sick. One of the reasons we give them the drugs to try and reduce the gastric aspirations. And sometimes those that gastric reflux can come up and go back down the airway. The balloon can help minimize this, but the balloon protecting the airway does have little microfolds in it where some of those secretions can go down and cause the patient to develop a ventilator-acquired pneumonia. So always try and sit your patient up a little bit. Providing sedation vacations is quite important because then you can assess the patient's readiness to extubate. And like I said, providing peptic ulcer disease prophylaxis. So we'll give them drugs to try and reduce the secretions in their tummy to try and prevent this reflux. Just to go back to the infection at the top here, how do we know our patient's got an infection? Well, we assess them very regularly. So you're going to be assessing their secretions. Have they increased? Have they changed colour? We'll assess for a rise in the patient temperature. So if they start to become febrile, we look for an increase in their white cell count. Commonly with our patients, they will have blood sent on a daily basis, and we'll be watching the white cell count. If that starts to rise in combination with the others, then we need to assess that possibly the patient has got a ventilated-associated pneumonia. And this is normally only assessed after 48 hours on a ventilator, that we can call it a ventilated-associated pneumonia rather than perhaps a community or a hospital-acquired pneumonia. So we keep them head up and we need to monitor those cuff pressures as well, because if the cuff starts to go down, then it could be that those microfolds will become bigger, allowing those secretions to go down. And then finally, just to say, one of the things that we always do with our patients, we provide deep vein thrombosis prophylaxis. So you see a lot of our patients placed on subcut injections to try and reduce the possibility of a DVT, and providing oral care. Some hospitals use chlorhexidine, some don't, but your hospital will have a policy that will dictate that for you. So you can see there's a lot of things we need to cover when looking after patients on a ventilator. A lot of the things that we do are focused on minimizing the complications from a ventilator, and also assessing whether the patient is ready for extubation or whether we need to increase the amount of support that we're giving them. Una.
Thank you, Jonathan. That was a great talk, really comprehensive in thinking about what factors help a patient to ventilate well or not ventilate so well, and how to improve ventilation in the patient. So I had a couple of questions out of it, two main ones, and I suppose earlier in your talk you talked about the importance of that clinical observation of the patient. And so one of my questions was, so say I was the nurse and I just, myself and the team had repositioned the patient, and the patient was back lying on their back, head of the bed up, as you said, but when I was undertaking my observations, I noticed that only one side of the patient's chest was moving and not the other. What would I do about that, or what should I think?
Okay, I mean, you've just moved the patient. So for me, the most common thing there is there a potential that the tube has moved as well. One of the things that we need to be very sure when we move a patient is that A, we're moving with the appropriate number of people, and B, that one of those people is responsible for looking after the endotracheal tube. Commonly what happens is that maybe the tapes have become a bit loose, or the patient has coughed as they've been turned over, and the combination of that means the tube may well have slipped down. If it's slipped down, then probably it's going to have gone down the right main bronchus. Because of the anatomy of the airway, it's more likely to go down the right main bronchus, and then you are ventilating effectively one lung. So what you need to do is obviously listen to the chest. You're going to call for help as well. That's probably one of the first things you're going to do. You need somebody experienced there if that's not you. You need to listen to the chest, perhaps look at the airway pressures may well have risen because now we're ventilating just one lung rather than two. Really depends whether you're using pressure control ventilation or volume control ventilation. You'll have different signs and symptoms, but it could be that the saturations might start to drop as well because, again, you're ventilating one lung. So what the action there would be is that you would probably turn the patient back on their back because that tube needs to be repositioned. You need someone experienced and airway trained to do that. So you get them over. It may be that you need to resedate the patient, and then somebody needs to make that decision as to whether you need to move that tube or not. That would be the most likely event. It could also be that the patient has dislodged a particularly big plug of sputum whilst you were moving them. They've plugged off one of their big airways. If they have, again, roll them back. Call for somebody experienced. There's no need to panic. If the saturations drop, then you're just going to turn the oxygen up and support them that way for a little while. If the patient becomes distressed, then it could be that we'll just give them a little bit more sedation. We can sort them out. We can either suction it out or do a bronchoscopy, for example, to get rid of that. So they're my two favourites for that particular scenario.
That's great, Jonathan. Great advice, actually, and very clearly put across. And so my other question then is in relation to sedation vacations you talked about, or sedation holds, as other people might know them. Can you tell me a little bit more about those, and what sort of things do we need to think about during sedation holds in regards to ventilation and the success of ventilation, or difficulties that patients might run into during sedation holds as well?
Okay. Sedation vacations or sedation holds or sedation holidays, they seem to have many different names. It's something that was advocated by Dr. John Kress over in Chicago many, many years ago now. And the current evidence is showing signs that really actually turning a patient's sedation off once a day if you can reduces the risk of things like delirium, reduces their length of stay in intensive care, and hopefully also reduces therefore their hospital stay. There's lots of protocols out there. There's the main reason for doing it, though, is that you are going to reduce the levels of sedation in the patient's circulation, which means that hopefully once you do finally take that decision to wake them up, it's going to be a quicker process than it otherwise would have been if they're almost swimming in sedation because we've never turned it off. It's going to take them a little longer to wake up. It was more important when we're using drugs like morphine and midazolam because they take a long time to wear off. Perhaps with drugs like propofol and alfentanil or fentanyl that we tend to use these days, it's not so critical, but I feel personally it's still quite important. So the plan is that the patient, as long as they're stable, you don't want to do it on a patient who's on 100% oxygen, for example. You never do it on a patient who's paralyzed for obvious reasons. You don't want to wake them up if they can't move. That's a scary thought for them and for us. You probably won't do it on a patient who's on a lot of cardiovascular support. So somebody who's on a lot of vasopressors, noradrenaline, norepinephrine, you wouldn't use it on them because they're just potentially going to become more unstable. But if you're happy to do it and they're on a decent level of oxygen, then it's just a case of making that decision, turning the sedation off, letting the patient become a little bit light. If you are sure that you are not going to let the patient wake up that day for whatever reason, once the patient becomes a little bit lighter, they start to move, they may start eye opening, then you turn the sedation back on. It's as simple as that. And that can take 20, 25 minutes potentially, might take a little longer, might be a little bit quicker. The important thing to say, though, is if you're going to do a sedation hold, obviously the patient needs to be monitored quite closely. This is not something you're going to do if the rest of the patient department is very busy, you've got sick patients next to you, you can't necessarily keep as close an eye because you need to be very careful with the patient and make sure that they are safe during this process. The other thing as well is if the patient's sedation is going to be turned off and you are going to think about actually waking them up, they are going to need a lot of reassurance when they wake up. They need to know where they are. They need to know who you are. They need to know when they are. And they'll need to be told that many times. Anyone who's been woken up from a general anesthetic will, or anyone that's seen anyone woken up from a general anesthetic, you will know that the patient will often ask the same question over and over and over again because they don't hold the information. But if you say it to them often enough and do the real proper nursing thing, hold their hand, reassure them, tell them they're safe, that big tube is because they've been unwell, but they're getting better now. And then hopefully if a sedation hold can be moved on to let's wean the sedation off, that's brilliant. If not, hopefully with a sedation hold, holiday, vacation, we've made that process a little bit simpler when we finally come to do it. So I'm a big advocate of sedation holds.
Thank you, Jonathan, and thank you again for a really interesting and informative talk. And I really love that there at the end where you brought in about the being person-centered to the patient, remembering they are communicating with them, how frightening an experience that might be to them, and that as the nurse, what you can do to reassure them and support them on that weaning process.
I'm a nurse to the core, Una, so that part
Brilliant.
of me will never leave my side. So
brilliant. Thank you, Jonathan.
Okay, no problem. Thank you.